Great. So welcome to this 40th Pain Journal Club on Mumbai Pain School platform. So today we are going to discuss about simulation in pain medicine, and we have another initiative which we are starting from today. Just to introduce the topics, I'm going to give a short 8-minute bites about the topic, and I have titled it "Sit Talks." So. Let us start. Pain medicine in India is actually quite diverse, and this is the situation for most of the world, including even the developed countries. And they have diverse issues, variable standards everywhere, different learning requirements, and as a result, there are different offerings. For example, in India, we have a 3-day or even 3-hour fellowship program, which is being offered online, and we also have a 3-year DM program. So that's the disparity. Money and time are involved, and physicians have to spend a lot of time, energies, money to learn even basic things. To overcome these situations, Mumbai Pain School was initiated by Panisha Spine Wellness and Pain Relief Center, and we have started online platform starting with Facebook, but we have moved to lots of video views, moved to Instagram, even Twitter. We are offering online courses. Most of them are on demand, just like Netflix, and they have both. We have both free and paid content. One of the only few organizations which are private and offering so much free content in the whole world. We have conducted our first hands-on workshop this month, and the next one is scheduled in December. So we are very fortunate to have expert faculty from all over the world, and it is said that the best teachers, they teach from the heart and not from the book. And about the journal club, what is a journal club? Journal club, it is nothing, just a club. The only difference being that here we critically evaluate the recent academic literature, which is based on a defined subject. Attendee participation is the most important. So those of you who are logged in, please participate, ask questions, type in the chat box, raise your hand if you want. We can allow you to speak as well. This is the venue for the first documented journal club. That's the Bart's, the modern Bart's Hospital, or the Bartholomew's Hospital, where Sir James Paget started the first one. After a few years, Sir William Osler in Montreal started the next documented journal club. Here, the cost of the journals was what prompted him to start this journal club. Even Harrison had his own journal club, which used to happen twice a week for twice a month for quite some time. He used to hold it fortnightly, and the aim there was critical evaluation of literature. Time is discipline, so I request speakers to please restrict to their timelines. Healthy skepticism or praise is most welcome, so please help us, all of you, with your comments and suggestions. A bit about me. I think most of you already know about me, so I straight on move to the introduction for the topic. So this is the first SID talk, simulation in pain medicine. So simulation per se is new, but even in pain medicine, this is now very important. So what is simulation? Simulation is something which is to do with a lot of role play or imagination, or kind of a situation where we are enacting the real scenario, and we are trying to give the user experience of the real thing while monitoring his or her parameters, behaviors, with the intent of teaching. So this is what is simulation. It started with you have a lot of examples in your real life. For example, this picture shows somebody who's put on a VR set and is kind of playing something or trying to touch something. So it is not very hard to imagine if you just start to imagine, and somebody monitors you, tries to teach you. It's not very difficult, and most of us can actually do it very well. So where did it start? It started with of course, with the place where nobody could afford accidents, which is the airline industry. And hence the pilots who were supposed to fly the stopwatch, who were supposed to time the flights, who were supposed to do everything with the fraction of the second. So they used to train on these simulators, which used to look and give exact feeling as if you are flying a plane. So many of us have also played on these, as games. But this is what simulation came from. And the benefit of simulation is that you are actually not experimenting on the real subject. It is extremely important. Just imagine a pilot who's being given the controls for the first time in the real plane, and he crashes the plane. Similarly, just imagine if some patient is there and some new colleague who's or new fellow or new trainee who's learning, inadvertently causes a damage to the patient. So then it can become quite difficult for the patient. So this is the benefit, but there is only one disadvantage, and that is the cost. I tried to list other disadvantages also, but they all come under the category of cost. Even the time of the manpower or whatever is required, it all comes under this cost only. So how popular is medical simulation? It's quite popular. And even simulated patients are nowadays available. And I'll explain you in brief. Simulation in anesthesia is pretty old. It's not new, surprisingly. And if you see most of the good standard textbooks, like even the Miller, they have full dedicated chapters on simulation. And I am sure that most of you have at least done a BLS, ACLS on a dummy or a mannequin, and you are at least aware of the basic simulator. That's a kind of a low fidelity simulator which is widely used. So simulator in anesthesia is not new. Nowadays we have very high fidelity simulators which are available. But simulation in pain medicine is now the real thing, and it's being adapted more and more. It's being adopted by more and more fellowship programs. And however, the intended audience for pain medicine can of course be the pain physicians, but also the doctors who are not pain physicians. Just remember, the biggest challenge which you face as pain physicians, probably many of you say that, okay, we don't get good referrals. So why not train the doctors to understand what's the role of a pain physician in a multidisciplinary team? And that's what your second audience is. In addition, nurses and of course other staff who deal with opioids, they must be trained using this simulation. It's got very drastic results. And in the end, the patients, of course, you will ask me, patients? Yes, of course, patients can also be trained using simulation on how to correctly avoid catastrophization and change their behaviors, pain patterns, and likewise. So what are the types of simulation which are available? It is high fidelity simulation, low fidelity task trainers. Like, for example, I'll demonstrate some pictures. But for example, your simple BLS mannequin where you just can press the thing and just blow air and the chest rises. That's a low fidelity task trainer. Or a live standardized patient. So your patient, a human being, is taught to behave in a certain way and is given a kind of a script, and he has to act as per the script. So that's a live standardized patient. And of course, the web based visual in virtual environment, this is also something which has got very popular. There are many difficult questions which can also be made easy through simulation. So just imagine, a doctor being trained on answering this question, which your patient will ask the most commonly: how much relief will I have, doctor? Or will this work for me? Or how long will this last? Or many such questions. Are these painkillers? And likewise, can you reduce the cost? What is the diagnostic procedure? So the answer to these difficult questions is very straightforward, which is realized by the pain physicians only after few years of practice. But if this is taught as a simulated scenario to the fresh trainee, I'm sure his practice can benefit a lot. So there are some special requirements so first is for simulation in pain medicine, because ours is a super specialty. So then definitely they have special requirements. First is a high quality interaction with patient and other doctors. So this interaction should be high quality. You cannot go in an unplanned fashion or in a place where audio visual is not proper. So this has to be a very high quality. Second is your MIPSI skill training. That is your procedures which we are doing, your pain procedures. So the skills should be trained or can be trained. And the third is crisis management. What to do when there is a crisis. For example, you gave a celiac plexus block and the BP dropped. Very simple crisis. Or for example, you are doing a probably a T2 T3 sympathetic and you just punctured the pleura. Now what to do? So similarly, you have a lot of situations where the crisis scenarios can be there, and these can be simulated very well in the simulation. So first, let us talk about the standardized patient. So what is a standardized patient? So in this situation, a human being or a subject is trained in behaving in a certain fashion, which is prescripted, and the trainee, they then ask the questions or examine or take the history as if they were treating a real patient, and this patient behaves in a certain way. So this is a very common method of certain examinations also, but this is all videographed so that after the trainee has examined, their good points can be illustrated, and even the points which they missed out or they could have done better, they are discussed in a debriefing scenario and situation. So a very common form of simulation method which is being used is the task trainers. So for example, on your screen now is a fluoro guided simulator. So you can see that this is a simulator, it's a mannequin, and our fellow trainee is trying to put in the needle here. And if you see, the images are very clear and there is no patient which is who is involved, and this can be very helpful in understanding the nuances. This is another picture showing a bigger view, and this can eliminate the time taken in a real patient, minimize the radiation exposure for the patient, and greatly increase the efficacy of the trainee in doing the procedure. So we are all most of us maybe are anesthesiologists, and we are familiar with the sono guided simulation. So this is the Blue Phantom, which is very popular, and but you'll be surprised to know that there are now many different types of sono guided simulation options which are available. There are task trainers as well as phantoms. Again, the only limiting factor here is the cost, nothing else. So here is another resource which can be used for simulation, which is the pain related anatomy in 3 dimensions. And there are multiple options. If you just Google anatomy 3D, and you'll get multiple software based options, and these can be used very well to train the fellows or the trainees in a simulated manner. It can be a part of a very big scenario also, or it can be just a task by itself. So this is also something which is used. As I mentioned, crisis training is extremely important, and other than the BLS, ACLS, which we all know by virtue of us being doctors, but it is extremely important to know special situations, like what can be the inadvertent side effects which are not uncommon, or complications of your procedures, and what are the steps to be taken so that the fellow is fully aware of this situation. Cadaveric training is another way wherein they are the closest to the humans, live patient, because of their structural similarities. And the only disadvantage is cost, time, and feasibility. Like for example, now in our country, we have a pandemic act, so cadaver acquisition is very limited, and as a result, very few places will be able to do the cadaveric workshops. But they are very high fidelity. They are actually almost as close to the real human as possible, because the time related changes will be there than nothing else. And if you can get fresh frozen cadavers, then it is just like the human body, or otherwise it can be slight texture changes and all. So this can be very good. This is a picture from our last hands-on workshop, which was held on 9th and 10th of October. So I'm just going to end this session with an example. So this is a example which was published in 2013, and this is an example which shows the decompensation during a stellate ganglion block, and this is how the scenario is designed. Okay, so when I design a scenario, I make a title, then I find out who are the learners, who are the target audience, what are the objectives, and then I form the teaching methodology and various states and what happens. So it's an algorithmic approach from here on. So many of you will think that this part is very difficult, but let me tell you, if you set all this right, then the rest of the part is not difficult. It's extremely easy and you all can do it very, very, very well. Okay. So this is just an example. You can review the video later on. I'm just not going into detail. Let's come here. So after the scenario, so if the trainee does the correct point, then it introduces, it goes to the next scenario. So this is the state 1, which is the baseline state. Then this is the state 2, this is the state 3, and this is the state 4. Okay. So this is how we move in a simulation scenario. And we have all the parameters actually set, and these are replicated by our mannequin. So at Patil Hospital or university, we have very high fidelity mannequins with which we can do all this very easily. So debriefing and discussion points are the most important part of any simulation. And here we discuss what happened and what happened correctly. It's a technique which is also used in various other fields, like, for example, in armies and air forces and, various other areas. And this is one of the most important and crucial area. For example, here you can ask, what is the differential diagnosis for respiratory arrest? What clinical signs and symptoms would help to solidify the diagnosis? So you can point out the correct points which your trainee has identified, and of course add in a very you can say friendly manner, and explain to the trainee. You can also refer to the video recordings which you would have done during the simulation. So this was it. I hope you have got a basic idea about simulation. Now we go, these are my references. And this ends the first talk, which was about simulation in pain medicine. And now we move on to the next part. So we have with us today Dr. Aanchal Sharma. She's done her MD anesthesia from PGI Chandigarh. She's done her fellowship in pain medicine from Chicago, United States. She's board certified from American Board of Pain Medicine. And she's right now working as consultant pain palliative care at Venkateshwar Hospital, Dwarka, New Delhi. So welcome, Dr. Aanchal. I will now request Dr. Maitri to start sharing her screen. And Maitri, you can put on your intro slide. I will introduce yourself and then you can start with the paper. I've already made you the co-host.
Is it seen? The screen is visible?
Yes, very well.
Yeah. Okay. And am I audible?
Yes, you're audible. You can just make it full screen.
I'll start.
So let me introduce Dr. Maitri Shah. She's DA anesthesiology, and she's current fellow in pain medicine at the pain medicine unit, Department of Anesthesiology, DYPU University School of Medicine, Navi, Mumbai. So over to you, Dr. Maitri.
Hi, good evening, everybody. So my topic for today is advancing simulation-based education in pain medicine. It's a pilot study taken from Pain Medicine Journal 2018, author Nalchini Singh et al. It performed at Education Program Division of Pain Medicine, School of Medicine, University of California. Introducing the article explores the potential for simulation-based education in the field of pain medicine as the modality for helping programs and trainees. Secondly, it highlighting the difficulties in implementing curriculum that clearly identifies progression of Accreditation Council for Graduate Medical Education ACGME milestones for individual learners. Third, pathways for demonstrating competency and patient safety, as well as vision for collaborative efforts in our field to develop, validate, and test a feasible simulation curriculum. Background. In 1999, the ACGME introduced 6 overarching core competencies such as patient care, medical knowledge, professionalism, interpersonal communication, system-based practice, practice-based learning, and improvements. 10 years later, the ACGME began transitioning the original core competency to outcome-based assessment, where measurable and observable development steps were assigned to competencies. Milestones for pain medicine were published in 2014 and revised in subsequent years. These milestones provide framework for trainees and the training programs to assess and document the trainee's trajectory for novice or proficient practitioner in unsupervised practice. This is an example of a case scenario, most commonly local anesthesia toxicity, which we might face during pain medicine procedures. So this is how it shows that this is a patient, 41 years old woman, who is posted for peripheral nerve block, and apparently she faces a local anesthesia toxicity and how it's supposed to be managed. So what all steps that has to be taken, and what medications and what other instruments or any other modalities can be used. This is a very generalized example, but this is how the basic simulation practice takes place. So moving forward, the conundrum of enacting milestones and where stimulation may fit. Certain methods for evaluation include assessing medical knowledge, internal examination for communication or professionalism, objective structured clinical exams or SKIs, peer reviews, patient feedback, case-based study, or standardized patients. Some other include direct, indirect supervision by faculty, oral presentations, charts, reviews, etc. Clinical skills in pain medicine, like difficult patient interaction and management of procedural complications, are vital for trainees to learn, but may not be common enough to be adequately supervised by the faculty. In such infrequent but vital scenarios, inadequate patient exposure can be compensated by a stimulation-based education platform. Anesthesiology and other fields have long embraced simulation as a tool for evaluation and training. Evidences suggest that these experiences result in high levels of satisfaction among participants and may improve the patient outcomes. Applying competency and milestones in pain medicine. Pain medicine involves the diagnosis, treatment, management of wide assortment of conditions, hence require detailed understanding of pharmacology, medical, psychological, and interventional procedures. Pain medicine trainees matriculate from diverse primary residency training with different backgrounds in patient care, such as anesthesia, neurology, psychiatry. Essential skills must be supplemented to ensure competent, safe, and independent practice through achieving competency, a standardized or a systemic approach. Stimulated learning in support of competency and milestones in pain medicine. Stimulated-based education has several advantages over traditional didactic, including they enhance ability for skills that are difficult to appraise, such as time management, awareness of limits, etc. Practice prior to treating live patients, refine case based on trainee experiences, etc., along with documenting achievements of demonstrable endpoints while offering direct hand-on experiences and clinical relevant experiences. Fourth, rare and high-yield clinical skills are learned and evaluated. Review of the literature on graduate level pain education and simulation. So PubMed research revealed 2 articles describing simulation for pain medicine fellow trainings. First, by Berner et al., described an interprofessional simulation-based curriculum encompassing physician, nurses, and physician fellows who were trained with 3 crisis source management algorithm and practice a bioethic case founded on responding to a medical error. Second, Holzer et al. Created a simulation curriculum based on trainee input, highlighting difficult conversations and one CRM algorithm. Participants reported increased comfort with challenging patient encounter after the training sessions. Also, both reports provided sample cases and instructor documents for the use by other practicing interventional pain management. Early experience in developing competency-based education using simulation. Simulating cases developed over several years that were tested among a single fellowship class 2012 to 13 to assess American Board of Anesthesiologists and ACGME achievements oriented competency and educational milestones were used. Faculty developed cases by identifying topics associated with desired proficiencies and relevant pain core competencies. The coordinating faculty member for this project was trained through several hours of mentorship with an in-house simulation expert and 1 year of development and testing of simulation scenarios among a previous fellowship class. 2 additional faculty members attended 1 hour training session focusing on rating the scenarios under the direction of coordinating faculty member. Through the IRB approved pilot study, pain management trainees performed 5 high-fidelity mannequin-based scenarios in an outpatient setting based on complications from common interventional pain procedures, which included iatrogenic pneumothorax, local anesthesia toxicity, SHIZA management, pacemaker dysfunction, and ventricular fibrillation. The SBE program consisted a written knowledge test, pre and post test, a realistic production of relevant emergency events, a critical action scoring system checklist for assessing and standardizing the performance of each trainee, a post-experience satisfaction survey. Trainee performance was evaluated and scored independently by 3 faculty members, 1 real-time coordinating faculty member, and 2 delayed video using critical action checklist at baseline and 6 months later. The group mean score of these 5 scenarios at baseline and its 6-month retest improvements were 4 on 5 scenarios. The inter-class correlation coefficient was used to assess the inter-rater reliability. So less than 0.2 was poor, 0.2 to 0.4 fair, 0.4 to 0.6 moderate, and 0.6 to 0.8 ICC was stated to be good. A test of knowledge, pre and post experience did not significantly change from uniformly high pre and post test scores. A brief satisfaction survey showed that 100% of the participants felt that the cases were relevant to practice and objectives were met. So this experience demonstrated the feasibility of simulated curriculum and highlights the need for consistent and accurate assessment tools along with rater training. A path forward. Simulator performance of trainees correlates with other clinical knowledge-based marker has advantage for training programs in need of demonstrating a required achievement of critically important milestones. Collectively working under the umbrella of professional societies and organizations could assure production of enough consistent results acceptable for simulation-based education platform for demonstrating core competency. Although such sophisticated and coordinate efforts may be difficult starting points for most pain medicine education programs, another option may be a web and computer-based virtual activities can offer greater accessibility for training programs and trainees. Quality patient care and safety goals, the need for training clinicians in managing complications without putting patients at risk. Simulation-based education offers the opportunity for all interventionists for treatment progressively move to more cost-efficient outpatient sites, which has the potential to encounter emergency situation and may be the sole clinician responsible for managing a life-threatening complication. SB also supports the opportunity for pain medicine to lead the way in raising the standards for safe procedural practice across the healthcare spectrum. The limitations accepted First, inconsistent rating of trainee among the faculty and to reduce rater bias and provide reproducible results between trainees and cases. The validity and reliability of the program is complicated by low number of participants, that is just one batch of pain medicine fellows in 1 year. The high cost and resource intensive nature of high fidelity stimulation. Critical analysis. First, a standardized or systemic approach to achieving ACGME milestones in pain fellowship is currently lacking. Application of similar structure SBE on diverse batches. Since this was just one batch, how the simulation works for different batches is also important. Next, inadequately supervised clinical skills, as there is a requirement of trained faculty for SBE. Last, the learner's transition from novice to expert with an emphasis on individual's learner's pace needs to be addressed. Lastly, the take-home messages, supplementation of traditional education with SB and evidence-based tool may be sensible approach for attaining diverse, multifaceted, and individualized educational experience may not be achievable in didactic or apprenticeship models. Thank you.
Thank you, Dr. Maitri, for this presentation. Over to you, Dr. Aanchal, if you want to ask anything or just for your comments.
Ma'am, we can't hear you.
So, yeah, this was a kind of, new thing for Indian setup, because we are not used to having simulation as a regular part of our residency training. But yes, as you have discussed in the beginning of the before the start of this lecture, that it has been used in the workshops and various ultrasound guided or some here and there in anesthesiology. But I think this paper, this discussion, kind of highlights the need for simulation-based assessment and training, the beginning of the residency program or fellowship. So maybe like the ACGME does, our ISSP can also, we all can get together and make cases and scenarios for incoming pain fellows, or maybe for anesthesia trainees as well, where we can discuss the complication, because these complications are actually so rare, like local anesthesia toxicity, which if happens, could be disastrous, but it may not even happen for 1 or 2 years, and the person does his fellowship and never has seen those complications, or maybe the pleural puncture, or stuff like that. So and also I think that these kind of training could help in start of procedural, like doing a plexus block, or doing any simple epidural injections. These simulation based trainings on mannequins can help if we put these scenarios, or we put this training for this in the start of the fellowship. This can make pain fellows do their transition a little easier from directly to the patient, and then rather than learning from the mannequins and then going over to the patients. Just one question I have, Dr. Maitri. What do you how do you see this simulation based training could be helpful for, since you're doing a fellowship, and in the start of the fellowship, since it's been few months in the start of the fellowship, what what things you faced, what challenges you faced, which you think if simulation based training would have been in place, you would have things become much easier?
So with my experience, I think in simulation, since the use of fluoroscopy, CM, with the patient positioning, the view, what we see in anesthesia, it was always a blind procedure, basic spinal or epidural to say. But with sir, we do practice on simulation on and off. So that thing is, first of all, my anxiety to do it on a real patient decreases. Secondly, I know what I'm going to deal with when I'm seeing the patient, or exactly where I'm supposed to go. My target is clear, my vision is clear, and that makes it very easy. And per se, I am very confident in what I know what I'm going to do to the patient, unless when I'm sir is performing and then I'm observing in the initial time. It becomes difficult because the anatomy also of every patient changes. The procedure is different, the requirement is different, but a standardized approach, if given early in my training, really helps to have a very basic info, which really speeds up the learning, because itself pain medicine is a very vast subject, and too much to learn and too less of a time. And it's very, very different from anesthesia. So just the orientation, as just to start with, would really help a lot. That's what I feel like. Lately we had a very beautiful cadaveric workshop also, that exactly stated that how diverse, or how what all can we do. Like just holding a USG probe is also so important. I might just not be able to do it directly on a patient, so the phantom or things like that are really, really helpful.
Right. And in fact, even the, doing the procedure on phantom, because when you are putting a needle and your focus is 100% on directing, having the needle reach the target, rather than you also see how your needle is going.
Positioning.
You kind of move your hand while you're trying to reach the target. So that is also one thing which is helpful. And then there are so many new procedures which gets introduced into the field of pain medicine every 6 months or any year, I think. And for even the people like us who have been practicing pain, but there's so many new procedures which keeps coming. And I think these simulation workshops can help the current pain medicine pain physicians as well. So this really gives us insight to add this in our regular curriculum too.
Yes. So because when I'm observing, sir is so effortless and was like, that's easy hai, but when you actually do it, it's a different ball game. So yeah.
Right. Overall, it was a good presentation, and I think good learning for all of us.
Great. So thank you, Dr. Maitri, for the excellent presentation, and thank you, Dr. Aanchal, for your inputs. So Dr. Aanchal, I'd just like to discuss how is it, what was it like when you were doing your fellowship there? I mean, in the initial months, and what all you were rotated through, and what is the current situation there? I'm sure you will be knowing much more than probably what.
Yeah. So in there, when with the start of anesthesia residency, you are not given. There is a first month of kind of you go as a trainee. You are a resident, but then you are a trainee. You're not allowed to work on the patient alone. And then in that 1 or 2 months, you are been to there is a separate lab, which is a simulation lab. And then you have to wash, and you have to be on the gown, that mannequin is clean and everything. So there is a monitor, and exactly OT like place. There is a other than the except patient, there is a mannequin lying, but rest of the scenario is same. You're at the head end, and they have kind of software which you could you could not be in that room, but from outside you could change the vital signs and the monitors, and you are just holding the mask like you would regularly intubate. And all of a sudden when you're trying to intubate, you will hear that patient is desaturating, and there'll be just somebody will be videotaping you and directly watching you as well, and then just see how you behave when the patient desaturates. And then you will be, after the session, you will be debriefed on you did not do 100% oxygen, or maybe you did not ask for help or something. There's few steps you miss in the beginning, and you did not ask for a bougie while you were intubating. So these are the anesthesiology. And then when you do regional anesthesia, then also you are supposed to do this on the blue phantom or the mannequins. And then the suddenly patient will have local anesthetic toxicity. Like in the real scenario you would have, the patient will, just go numb. Somebody will be saying patient is in asystole, and then you will respond accordingly. You'll ask for interlipid and you'll do stuff like this. So in the pain medicine also, there are, mannequins. The rep would come there, and then not for the basic procedures, but because you do that as a, because you keep seeing those as anesthesia residents as a well, because they rotate there in the pain medicine. But for the difficult procedures, like kyphoplasty, vertebroplasty, or like endoscopic procedures, there will be mannequins where you would just do on there as you would do in the regular. And then that's I think very easy transition that gives you a confidence as well when you approach the real patient.
Great. So I think this is a lot of difference which is there. We are very fortunate actually that because in our institution we have all the setup. I think Maitri has seen all that which we have. We have all these CAE mannequins, and even the most costliest ones which are very high fidelity. You can actually put in the gas, connect a real boils, real machine, connect, give the everything is there. And in addition, for anesthesia also, for pain also, we have got quite a few things which we are doing. The pictures which we showed, they were our pictures. So I think
Right.
we got a lot of stuff there. And of course, we are improving. We are going to create some scenarios. We are collaborating with the people around the world who are actually doing this stuff there, and trying to bring that to our fellowship program. So great. Thank you once again for the excellent discussion. So moving on to the next steps. The secret of getting things done is to act. So guys, join our mailing list. Some of you are new. I've also posted the WhatsApp group link in the chat. We'll also get in the email. This is very important. Please give me your suggestions for the small talks. Like today, I covered simulation pain medicine in a very nutshell, just to give you an overview in a very short time. I'm sure I must have exceeded by 1 or 2 minutes, but actually it's much more. So it was just an overview, and your suggestions, comments, they are most welcome. And of course, we have this option. If you publish something really good, you think you want to highlight your work, present with us, send us your application. We be a part of this journal club. So we are right now accepting applications wherein we will allow you to present a journal, and the link for this is already posted in the chat. If you don't get it, if you're viewing it on Facebook or you watch the recording later on, please just mail it to mail us on mumbaiPainSchool@gmail.com, and we're going to send you the link as well. So with these words, thank you all for joining in. We almost resumed after say 4 weeks or more, but in these 4 weeks we have accomplished the first, I think it was the first combined cadaveric and ultrasound fluoro guided workshop in India after the COVID. So I think we have been able to achieve this much. So looking forward to seeing you all very soon in the next journal club next week. Stay tuned. Bye bye.